So this is vertical deviations associated. You could have manifestation or latent manifest nystagmus, or even manifest nystagmus. In this child, you see there's a nystagmus which is present now. We cover the nystagmus is increasing and it is beating towards the left eye now. When we cover the left eye, it will beat towards right eye. So when we cover the left eye, so it's basically beating towards the fixing eye. So that's another feature that we could have in infantile esotropia. And essentially speaking, if you look at the management of infantile esotropia, the first step in management is refraction, and what you need to do is give a full cyclophysic correction, which means you do your retinoscopy and under atropine or cyclophysic, you need a strong cyclophysic, you subtract only for the distance, not for the cycloplegia, and prescribe those glasses to the children, and that's the more important portion of it. Then we will come down to surgical management in a bit. Fusion sometimes between 1:1 as while waiting for surgery, or if there's an amblyopia associated, then you could give a fusion for that. As far as surgery is concerned, the idea is you follow certain normograms. You need to address the other associated things, let's say like the obliques. When is it that you need to operate? Usually the best time would be between 4 to 6 months of age and up to about a year. If child is older, sometimes obviously you need to operate, and all infantile esotropes need to undergo surgery. The second case that we will present is a case of refractive esotropia. Look at this child who is having esotropia. It is the right emergency at the moment. When you give a refractive correction, the esotropia is entirely corrected. So this is the case of a refractive esotropia where the refractive correction, again a full cyclophysic correction is what needs to be given. It takes care of the refractive layer altogether, and we come to a circumstance where there is now an associated residual esotropia which is left, for which surgery would then need to be treated. Again, a full cyclophysic refractive correction needs to be given to such children. The next esotropia that we come to is accommodative. Look at this child having esotropia. We give glasses basically, but despite that, when you look for near, he's again having esotropia. But if you see that when he sees through his bifocal segment, which is the near eye segment, the esotropia disappears. So this is classically a case where the accommodation is causing the esotropia, and it's an accommodative esotropia, so to speak. Again, and the treatment for such cases, the important thing to remember is bifocals. Of course, you need to give full cyclophysic refraction, but bifocals and how much bifocals has to be given depends upon the AC by A ratio is 1, but also the lowest amount of bifocal that will take care of the esotropia from here. And it's important to show accommodative target. So here we show a benefit which probably is not the ideal target, but however, let's say if we use a large fixation target, so a near charge that would be used, child has to accommodate, and then target after that will be used. But there is still leftover, you could do surgery. If somebody is not willing to wear bifocals, or some reason cannot wear bifocals, you could consider another form of surgery that will come to, which is easily rectal myopexy. But it's not the routine prescribed. The idea is to give bifocal glasses. The next form of esotropia that we can come to this is a convergent excess esotropia, which is again like in accommodative esotropia. This child wearing glasses, nothing is having esotropia, but when you correct him for the making see through the near eye or the bifocal segment, the esotropia disappears. And this is how the ideal bifocals should be given. They should be bisecting the pupil. Right? Giving like this does not work because the child will be seeing always through the upper segment and will not be using the lower segment. Unlike an adult will do such, these exactly bifocals are required for children. It's important to have a segment bisecting the pupil. The last one that I want to discuss quickly is partially accommodative esotropia. Here you see there is an esotropia which is increasing for accommodation. Despite giving the near eye, you can still see there is some amount of esotropia which is left over. And this here we need to do a surgical correction for the non-dynamic portion of esotropia. Essentially speaking, the portion which is left over now after you've given the refractive correction and you've given the near, this only the near correction or a bifocals have been given. For that you have to do surgery which is again as per the normograms, and in most of the eye is aligned now even from here. So this is in a nutshell the basic types of esotropia that we will come across and how to manage them.